Good day, everyone. I'm Dr. Judith Sugay, and welcome to our discussion about cardiovascular disorder. And this is particularly about heart failure. So, at the end of this discussion, the students will be able to explain the pathophysiology of heart failure, differentiate left-sided from right-sided heart failure, and use the nursing process as framework for care, and be able to describe the nursing care of patients with HF or heart failure. So, let's start here. So, when we say heart failure, it refers to the inability of the heart to pump sufficient blood to meet the needs of the tissues, okay, for oxygen and nutrients. In the past, heart failure is referred to as congestive heart failure or CHF. It is because many people experience pulmonary or peripheral congestion. However, currently, HF or heart failure is recognized as a syndrome which is characterized by fluid signs and symptoms of fluid overload. So, also, probably it has inadequate tissue perfusion. So, this is a normal heart, and compared to a thickening of the ventricular chambers and smaller filling capacity and ejection of blood because again of the thickening of the ventricular chambers. So let's discuss the pathophysiology. Let's start with, of course, what really happens. Why is there heart failure? So heart failure arises because of various cardiovascular condition, probably hypertension, coronary artery disease, valvular disease. Okay, so these conditions can result to either systolic failure or diastolic failure, or even both. And then later on, it can be observed that there's a significant myocardial dysfunction. Usually, it happens before the patient experiences the following signs and symptoms, such as shortness of breathing, edema, and fatigue. So let's continue. Okay, so as HF develops, the body now activates neurohormonal compensatory mechanisms. Okay, and these mechanisms represent the body's attempt to cope with heart failure and responsible for the signs and symptoms that eventually will develop. So to continue once again, next is that what happens now to the systolic heart failure. Systolic heart failure results in decreased blood volume being ejected in the ventricle. If this happens, then the decreased ventricular stretch, okay, and is sensed by baroreceptors in the aortic and carotid bodies. The sympathetic nervous system is then stimulated to release epinephrine, okay, and the purpose is to increase the heart rate and contractility and support the failing myocardium. But the continued response has multiple effects. So the sympathetic stimulation causes vasoconstriction of the skin, gastrointestinal tract, and kidneys. Let's pay attention particularly to kidneys, okay? So, in kidneys, there will be a decrease in renal perfusion. Okay, so this is due to low cardiac output and vasoconstriction, okay, which then causes the release of renin by the kidneys again. So, when we ask, okay, what is renin? Renin promotes the formation of angiotensin 1. This is actually a benign inactive substance, and then angiotensin converting enzyme, or ACE, in the lumen of pulmonary blood vessels converts the angiotensin 1 to angiotensin 2. This is now a potent vasoconstrictor, which then increases the blood pressure and afterload. Okay, so angiotensin 2 also stimulates the release of aldosterone, which is from the adrenal cortex, okay, which will result in sodium and fluid retention, okay, by the renal tubules. So, next is that there will be stimulation of the ADH or the antidiuretic hormone, and this will now lead to fluid volume overload. So, as the heart's workload increases, contractility of the myocardial muscle fibers decreases. So, if that happens, then there will be now a decrease in contractility, which will result in increased in end diastolic blood volume in the ventricle. So, the myocardial muscle fibers will now increase in size, and you can check, of course, or observe the ventricular dilation. So, this will increase the stress on the ventricular wall. Okay, so one way of the heart can compensate for the increased workload is to increase the thickness of the heart muscle, which is called the ventricular hypertrophy. So this hypertrophy will now result in abnormal proliferation of the myocardial cells. It is a process of ventricular remodeling. So this is under the influence of neurohormones or angiotensin II. If that happens, a large myocardial cells are produced and are dysfunctional, okay, and eventually die early. So, leaving the normal cells to struggle to maintain normal cardiac output. And then the compensatory mechanisms of HF have been called the vicious cycle of heart failure, because the heart cannot respond and the failure becomes worse. So, later on, diastolic heart failure develops because of the increased workload on the heart, which will now respond by increasing the number and size of myocardial cells. So, there will be less blood in the ventricular filling, and then the pressures can cause the same neurohormonal responses as described in the systolic HF. So, we have here the combination actually of having, or a presentation, this is according to AHA, okay, who are at risk for heart failure, okay, and then what happens when there's heart failure. So, as you can see here, it has several stages. So, for stage A, at risk for heart failure, we have, okay, at high risk for HF but without structural heart disease or symptoms of HF. So we have patients with hypertension, coronary artery disease or atherosclerotic disease, diabetes, obesity, metabolic syndrome, patients using cardiotoxins, patients with family history of diseases like that of cardiomyopathy. Okay, so this is now after finding out, of course, for the structural heart disease. Then let's see the next stage. So there's in terms of structural heart disease, okay, this one structural heart disease but without signs and symptoms still of heart failure. So patients with previous MI or myocardial infarction, left ventricular remodeling, and then asymptomatic valvular disease. So, for the development of symptoms of heart failure, so the structural heart disease with prior or current symptoms of heart failure, example, known structural heart disease and shortness of breath, fatigue, reduced exercise tolerance. And then next, it will move to stage D, which is refractory symptoms of heart failure at rest. So this one, it requires special intervention. For example, patients who have marked symptoms at rest despite maximal medications therapy. So those who are currently hospitalized or cannot be safely discharged from the hospital without special interventions. So at the bottom, for each stage are therapy goals. Okay, so let's start. If under stage A, given these diseases, all right, so again, therapy goals would be treat hypertension, advise smoking cessation, treat lipid disorders, encourage regular exercise, discourage alcohol intake as well as illicit drug use, control metabolic syndrome. So, below are medications, okay? So, ACE inhibitors, okay, is an example. So, for stage B, where there is, or there are rather patients with previous MI, LV remodeling, and so on, okay? So, again, we treat each disease, and then included drugs are the same of stage A, okay, that is inhibitor, ARB in appropriate patients, beta blockers, again, in appropriate patients, depending again on the condition that has been mentioned here in this stage. And then moving on to stage C, again, interventions for given diseases in this stage, and then drugs for routine use could be diuretics if there's fluid retention, ACE inhibitors, beta blockers, and again, must be able to check the disease itself, okay? And then lastly, we have appropriate measures given on the under this stage D, and then there are options of compassionate end-of-life care or hospice, okay, and then extraordinary measures such as heart transplant, chronic inotropes, and experimental surgery or drugs, depending on the recommendation of the physician. So, what are the clinical manifestations? So, for general clinical manifestations of heart failure is that there's fatigue, decreased activity tolerance, dependent edema, okay? So, that one you can observe that there's edema towards the feet of the client, and then weight gain. So, in terms of cardiovascular, so there's a third heart sound. It could be that of murmur, galloping, and then the apical impulse is enlarged with lateral displacement. You can also see symptoms of pallor and cyanosis, jugular vein distension or JVD. Okay, and then for the respiratory, there's dyspnea on exertion. You can also hear pulmonary crackles. That's not clear with cough. And then orthopnea position. Okay, and then for the cerebrovascular, there's altered mental status, and then there's lightheadedness. For renal, there's oliguria, so decreased frequency during the day, and then nocturia. Okay, and then for the GIT, they manifest anorexia, enlarged liver. There's also ascites. Okay, so actually here, just to present to you the often being classified, okay? So heart failure, okay, is being classified here. This is according to New York Heart Association classification. So when you say one, okay, so the first classification is that there is cardiac disease, but there's no symptoms, there's and no limitation in ordinary physical activity. Second classification, there's mild symptoms of heart failure already, and there's slight limitation during ordinary activity. And then for the third, there's significant limitation in the activity due to symptoms, comfortable only at rest. And then for the fourth, there's severe limitations, so symptoms are evident even while at rest. So let's describe here the left-sided heart failure. Okay, so in left-sided heart failure, pulmonary congestion, okay, happens when the left ventricle cannot effectively pump the blood out of the ventricle, okay, and then into the aorta and into the systemic circulation. So the increase in left ventricular and end diastolic blood volume increases, okay, the left ventricular and diastole pressure. Okay, so which will then decrease the blood flow from the left atrium into the left ventricle during the diastole. Okay, so the blood volume, okay, and pressure now in the left atrium increases, and this will also decrease okay, the blood flow from the pulmonary vessels. Whereas, to continue, pulmonary venous blood volume and pressure increases. This will now force fluid from pulmonary capillaries into the pulmonary tissues and alveoli, and you can observe for the client having like pulmonary interstitial edema, and there's difficulty of breathing, dyspnea, because of impaired gas exchange. Now, what could be the manifestations or clinical manifestations? So you can observe that the client has dry and unproductive cough. Okay. Next is one of the adventitious breath sounds that can be heard. We have crackles, and then there's also reduced cardiac output. There's decreased in stroke volume, which causes the sympathetic nervous system, okay, to have tachycardia, and then the pulse rates characteristic includes weak and thready pulse. The patient also easily gets tired and has difficulty sleeping, again because of several discomforts, like that, for example, of coughing, okay, and symptoms of decreased cardiac output. On the other hand, we have the right-sided heart failure. So, when the right ventricle fails, there's congestion in the peripheral tissues and in the viscera. Okay, the viscera now predominates. So, this happens, okay, because the right side of the heart cannot eject blood and cannot accommodate all the blood that normally returns, okay, from the venous circulation. So, there will be now increased venous pressure, which will lead to jugular vein distension and increased capillary hydrostatic pressure throughout the venous system. Let's now see what are the clinical manifestations of the patient. So, there could be edema of the lower extremities. There could be enlargement of the liver, hepatomegaly. There could be accumulation of fluid in the peritoneal cavity, so ascites, anorexia, nausea, weakness as well, weight gain due to fluid retention. Okay. So, in terms of medical management, we have here several medications. Okay, some of the medications that's being used. So, we have the ACE inhibitors or the angiotensin converting enzyme. So, an example is captopril. Okay, what could be the effect? So, the blood pressure and afterload decreases. The patient is being relieved with signs and symptoms of heart failure. And this will now prevent progression of heart failure. So, the nurse should observe for symptomatic hypotension, okay, because of this one, okay. Increased serum potassium, cough, worsening of renal function, okay. So, next we have the beta-adrenergic blocking agents. Example, we have losartan. This now will dilate the blood vessels, okay, and will decrease the afterload. So, later on, there will be lesser signs of heart failure, and then there will be improvement as the patient tries to exercise. Okay, and then the nurse will now observe for decreased heart rate. Are there any symptoms of hypotension and fatigue? Next, we have diuretics. So, for diuretics, an example is the furosemide. So, this one decreases the fluid volume overload. So, with that, there will now also be decreased in the signs and symptoms of heart failure. So, the nurse should observe for electrolyte abnormalities and renal dysfunction, diuretic resistance as well, and decreased in blood pressure. So, we also have calcium channel blockers, okay? An example is amlodipine. So, in this drug, there's vasodilation and reduction of the sympathetic resistance. So, the nurse should observe for symptomatic hypotension, drowsiness, dizziness. Okay, just to emphasize, for every observation, you must report this to the physician and always document your assessment and provide safety to your patient. So, what could be the diagnostic findings? So, there could be echocardiogram, okay, to check the heart movement, and then the doctor can also order for some laboratory tests. So, that must include the blood urea, nitrogen, creatinine. This one's for the renal function, complete blood count, CBC, to check as well if there's any other like deviations, and thyroid stimulating hormone, serum electrolytes, urinalysis. Okay, chest x-ray. So, chest x-ray for to determine if there's any fluid accumulation in the chest, because again, there's a one of the clinical manifestation is fluid overload. And then there's also ECG for observation if there's any like arrhythmia, atrial fibrillation, and so many more. And then cardiac stress test to determine as well the capacity of the patient in doing like activity or exercise, and recording the heart rate and more of the heart activity. So, now into the nursing process, let's based on your assessment, okay, considering the risk factors, considering the findings, clinical manifestations. Now, one of the nursing diagnoses are the following: activity intolerance related to decreased cardiac output, with the goal of course, having being able to do activities, or that there will be activity tolerance already for the patient. And then excess fluid volume related to heart failure syndrome. So here, after nursing intervention, the patient will be able to be relieved from fluid overload symptoms. And then anxiety related to inadequate oxygenation. So, after nursing intervention, the patient will be able to manage his or her anxiety. Okay, so here are some of the few nursing interventions. So, promote activity tolerance, manage fluid volume intake. You must also control the anxiety, monitor, manage as well potential complications by again checking everything, including that of drug medication, documenting everything, reporting significant findings to the doctor, and carrying out the doctor's order. Okay, so again, as part of the outcomes, we look forward that the patient demonstrates tolerance of increased activity, maintains blood fluid balance, less anxious of the situation or condition, and adheres to self-care regimen. So, here are the references that you can also use. Alright, so thank you for listening, and if you have any questions, please let me know during our discussion. Okay, so bye everyone. Thank you for listening.